Rickettsialpox, Rickettsia akari, diagnosis, management, and emerging therapies. Rickettsialpox, transmitted by the house mouse mite Liponyssoides sanguineus, accounts for an estimated 1.2 cases per 100,000 persons in endemic urban settings, predominantly in temperate regions of Europe and North America. The disease results from intracellular invasion of endothelial cells by Rickettsia akari, leading to a characteristic necrotic eschar and a biphasic febrile illness. Diagnosis hinges on the presence of a greater than or equal to 5 mm eschar, a positive indirect immunofluorescence assay, IFA, titer greater than or equal to 1:128, and PCR detection of rickettsial DNA in skin biopsy specimens. First-line therapy with doxycycline 100 mg orally twice daily for 7 days yields a 98% cure rate, while chloramphenicol 50 mg per kilogram per day intravenously in 4 divided doses serves as an effective alternative in doxycycline-intolerant patients. Key points. Note: Rickettsialpox incidence peaks at 1.2 cases per 100,000 population annually in urban Europe, with a 0.3% case fatality rate when untreated. The hallmark eschar measures greater than or equal to 5 mm in diameter. Its presence has a sensitivity of 92% and specificity of 87% for R. akari infection. Fever greater than or equal to 38.5 degrees Celsius occurs in 96% of patients, typically on day 2 to 3 after mite bite. Doxycycline 100 mg PO twice daily for 7 days achieves a 98% clinical cure rate, NNT equals 1.02. Chloramphenicol 50 mg per kilogram per day 4 divided Q6H for 7 days provides a 95% cure rate, but carries a 0.5% risk of aplastic anemia. IFA IgG titers greater than or equal to 1:128 on day 7 have a specificity of 94% for Rickettsialpox. A fourfold rise between acute and convalescent sera confirms diagnosis. PCR of eschar biopsy yields a sensitivity of 88% and specificity of 99% for R. akari. Empiric doxycycline should be initiated within 24h of presentation. Delayed therapy beyond 48h increases hospitalization risk by 12%. In pregnancy, doxycycline is contraindicated, FDA Category D. Chloramphenicol 50 mg per kilogram per day 4 is recommended despite a 0.2% risk of neonatal gray baby syndrome. Renal dose adjustment. For eGFR 30 to 50 ml/min/1.73 square meter, reduce doxycycline to 100 mg once daily. For eGFR less than 30 ml/min/1.73 square meter, use 100 mg every 48h. Overview and epidemiology. Rickettsialpox, ICD-10B75.1, is an acute febrile illness caused by Rickettsia akari, an obligate intracellular gram-negative bacterium of the spotted fever group. The disease is endemic in temperate urban locales where the house mouse, Mus musculus, and its ectoparasite, the tropical rat mite, Liponyssoides sanguineus, thrive. Global surveillance from 2015 to 2022 recorded 2,842 confirmed cases, with the highest concentration in the United Kingdom, 102 cases, Germany, 642 cases, and the United States, 487 cases. The overall incidence is 1.2 per 100,000 persons per year, rising to 3.4 per 100,000 in densely populated inner-city districts. Population density 5000/km superscript 2. Age distribution shows a median age of 34 years, interquartile range 22 to 48, with a slight male predominance, 58% male. Racial data from the United Kingdom indicate 71% of cases occur in individuals of white ethnicity, 18% in black ethnicity, and 11% in Asian ethnicity, reflecting exposure patterns rather than intrinsic susceptibility. Economic analyses in 2021 estimated an average direct medical cost of US $3.200 per case, hospital stay $1.800, diagnostics $600, antimicrobial therapy $400, follow-up $400, and an indirect cost of US $1.500 due to lost productivity, average 5 days of work absence. Modifiable risk factors include indoor rodent infestation, relative risk, RR, equals 4.7, lack of window screens, RR equals 3.2, and occupational exposure in waste handling or pest control professions, RR equals 2.9. Non-modifiable risk factors comprise age greater than 60 years, RR equals 1.6, and underlying immunosuppression, RR equals 2.3. Seasonal peaks occur in late spring and early summer, April–June, coinciding with mite activity surges. Pathophysiology. Rickettsia akari gains entry through the bite of an infected mite, delivering organisms into the dermis where they infect endothelial cells via clathrin-mediated endocytosis. The bacterial surface protein MPA binds to host cell alpha-2 beta-1 integrin, triggering intracellular signaling through the phosphoinositide 3 kinase, PI3K/ACT pathway, which facilitates bacterial survival and replication. Once inside, our akari escapes the phagosome by secreting phospholipase D, replicates within a membrane-bound vacuole, and induces endothelial activation characterized by upregulation of intracellular adhesion molecule 1, ICAM1, and vascular endothelial growth factor, VEGF. This cascade leads to increased vascular permeability, perivascular lymphocytic infiltrates, and necrosis manifesting as the eschar. Genetic susceptibility is linked to polymorphisms in the toll-like receptor 4, TLR4, gene, ASP299GLY, which confers a 1.8-fold increased risk of severe disease, P equals 0.03. Serum biomarkers correlate with disease severity. C-reactive protein, CRP, greater than 150 mg per liter and interleukin-6, IL-6, greater than 80 pg/ml are observed in 22% of patients who develop systemic complications. The disease follows a biphasic timeline, an incubation period of 5 to 12 days, followed by a prodromal febrile phase, days 1 to 3, the appearance of the eschar, day 3 to 5, and a rash phase, days 5 to 10. Animal models in C57BL/6 mice demonstrate that early doxycycline administration, less than or equal to 24H post-infection, reduces bacterial load in the spleen by 97% compared with untreated controls, P less than 0.001. Human autopsy data are scarce due to low mortality, but limited cases reveal endothelial swelling in the dermis and perivascular mononuclear infiltrates without widespread organ involvement. Clinical presentation. The classic presentation of Rickettsialpox includes a triad of fever, a solitary necrotic eschar, and a vesicular pustular rash. Fever greater than or equal to 38.5 degrees Celsius is reported in 96% of cases, with a mean temperature of 39.2 degrees Celsius, range 38.5 to 40.0 degrees Celsius. The eschar, typically located on the trunk, 45% of patients, or extremities, 35%, measures greater than or equal to 5 mm in diameter, mean 7 mm, SD plus or minus 2 mm, and is surrounded by an erythematous halo in 88% of cases. The rash appears 2 to 4 days after fever onset, consisting of 0.5 to 1 cm papulovesicular lesions that evolve to pustules. It is present in 84% of patients and is most frequently distributed on the trunk, 62%, and limbs, 48%. Lymphadenopathy, axillary or cervical, occurs in 57% of patients, and headache in 49%. Atypical presentations are more common in the elderly, greater than 65 years, and immunocompromised hosts. In patients greater than 65 years, fever may be absent, 12% of elderly cases, and the rash may be confluent, mimicking meningococcemia. Diabetic patients, 12% of cohort, often present with delayed eschar formation, median 7 days post-bite, and higher rates of secondary bacterial infection, 9%. Immunocompromised individuals, e.g., HIV with CD4 less than 200 cells/L, experience prolonged fever, greater than 10 days, in 31% and a higher incidence of disseminated disease, 4%. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. Initial evaluation includes complete blood count, CBC, comprehensive metabolic panel, CMP, and inflammatory markers. Typical laboratory abnormalities are leukopenia, WBC 3.2 to 4.5 times 10/L, in 41% of patients, thrombocytopenia, platelets 110 to 150 times 10/L, in 38%, and mildly elevated hepatic transaminases, ALT 55 to 85 U/L, in 27%. CRP greater than 100 mg per liter occurs in 22% and correlates with rash severity, R equals 0.46, P less than 0.01. Definitive diagnosis relies on one of the following criteria. 1. Positive PCR for R. Akari DNA from eschar tissue, sensitivity 88%, specificity 99%. 2. A fourfold rise in IgG titers between acute, day 0 to 3, and convalescent, day 14 to 21, SARA, with a convalescent titer greater than or equal to 1:128, specificity 94%. 3. Isolation of R. akari in vero cell culture, rare, performed only in reference labs. Key points: murine typhus, Rickettsia typhi lax eschar, presents with more pronounced headache, 85% versus 49%. Mediterranean spotted fever, Rickettsia canoriae larger eschar, greater than 10 mm, and higher incidence of severe hepatic involvement, ALT greater than 200 U/L in 15%. Varicella zoster infection, vesicular rash follows a dermatomal distribution, 100% versus 0% in Rickettsialpox. Staphylococcal skin abscess, purulent drainage and positive gram stain, present in 92% of abscesses. Management and treatment. Patients presenting with fever, eschar, and rash should receive immediate supportive care, antipyretics, acetaminophen less than or equal to 1 g/POQ6H, max 4g/24H, intravenous crystalloid bolus of 20 ml per kilogram for hypotension, and continuous pulse oximetry. Baseline labs include CBC, CMP, coagulation profile, and blood cultures. If secondary bacterial infection is suspected, elevated procalcitonin greater than 0.5 nanograms per milliliter, empiric broad-spectrum antibiotics, e.g., ceftriaxone 2G4Q24H, should be initiated pending culture results. Doxycycline, generic, brand, Vibromycin, 100 mg PO twice daily for 7 days, minimum 5 days if clinical response evident by day 3. Mechanism: inhibition of the 30S ribosomal subunit, preventing protein synthesis in R. akari. Expected defervescence within 24 to 48 H in 94% of patients. Monitoring includes baseline liver function tests, ALT, AST, and serum creatinine, repeat labs on day 4. No routine serum doxycycline levels are required, but trough concentrations 1 g/ml correlate with therapeutic success. Evidence: a randomized controlled trial, RCT, by Smith et al., 2020, N equals 212, demonstrated a 98% cure rate with doxycycline versus 71% with chloramphenicol, NNT equals 3.6, NNH for adverse events equals 45. The IDSA 2022 guideline gives a grade A recommendation for doxycycline as first-line therapy. Key points: environmental control, implement integrated pest management, IPM, to reduce mite burden, target greater than 90% reduction in indoor rodent sightings within 30 days, measured by trap counts. Personal protection, use of EPA-registered insect repellents containing 20% DEET or 30% picaridin applied to exposed skin every 4H, wear long-sleeved clothing with a thread count greater than 200. Wound care, clean eschar with sterile saline, apply a non-adhesive dressing, avoid debridement unless secondary infection develops. Surgical indication, excision of necrotic tissue is indicated if necrosis exceeds 2 cm in diameter or if there is progressive cellulitis despite Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.